Sure.
Yep.
Okay, I think we should be good to go. You know what they say, the bitterest truth beats the sweetest lie. But in the startup world, founders often get served a dessert platter of sugar-coated nonsense, empty praise, vague interest, and ghosted emails. Instead of the cold, hard truth they actually need, like a purchase order or a check. And that's where EthAum comes in. Our roast sessions are designed to turn up the heat, live and unfiltered. Founders face tough questions, real feedback, and zero fluff from seasoned experts. It's like Shark Tank meets group therapy, but with more burn and less hugging. And today, stepping into the fire is Miki, founder and CEO of Vitalerter, dialing in from Israel. He's on the hot seat today, ready to be grilled constructively by a panel of truth-slinging pros. Now, I will request our panelists to introduce themselves. If I may request Kedar to go first. Kedar, please, a quick introduction.
Yeah, thanks, Pankaj. First of all, thank to EthAum Venture Partners for inviting me to this panel. It's always exciting to see and evaluate and look at patient-centric innovations through these panels. I've been in the healthcare domain for last 2.5+ decades now. Majority of that is with Philips in different functions. Presently, I accelerate deep tech and healthcare innovations, partnering with startups, scalers, incubators, different agencies, mainly leveraging my experience across corporate strategy, innovation management, ecosystem orchestration, and then also about corporate venturing. So I'm looking forward to listening to Miki share perspectives. Some of the other areas that I have dived deeper is AI in radiology, cardiology, oncology, minimally invasive surgeries, of course, emergency care, acute care, and a lot of SaaS and then devices. Apart from all of these ologies or technology part, I also dive deeper into access and impact related solutions. So excited to be at the panel and then contributing.
Thanks a lot, Kedar. Really appreciate your time today. And I'm sure that your experience at Philips while evaluating startups will be extremely beneficial for today's conversation. So really appreciate your time today. Timothy, may I request you to go next, please?
Yeah, absolutely. I'm Tim Poore. I'm the Chief Revenue Officer and co-founder of a company called Post-Acute and Elder Care Platform. It's an AI platform we've developed with the partnership with the Mayo Clinic. Prior to that, I had a startup, ATP Healthcare, which we were involved in the acute to post-acute transition space. I have about a decade's worth of experience working in the post-acute care industry in the United States mainly. And before that, I worked in export controls for an export control think tank for about a decade. And I'm really excited to hear what Miki has to share with us today, and look forward to our conversation.
Fantastic. Thanks a lot, Tim. Really appreciate your time today. And as you may have discussed with Miki in inside conversations, they are planning to expand in the US, and I'm sure that your understanding about the US market will definitely help him quite a lot. So really appreciate your time today. Ayman, may I request you to go next, please?
Yeah, thank you. Thank you very much. And nice to meet you all. And my name is Ayman. I'm General Manager for Open Medical UK, a company specialized in digitizing the healthcare workflows and processes. My experience in the domain of healthcare, business healthcare, is around 17 years, mainly in strategic expansion globally, and helping startups also to innovate and helping them in the go-to-market. My background is biomedical engineering.
Fantastic.
Nice to meet you all, and happy to, participate to give insightful push to very impactful solutions.
Thank you. Ayman, appreciate your time. And obviously your experience in the UK and Middle East market is going to be quite impactful for this conversation. So really appreciate it. Last but not the least, Vlastimil, may I request you to go next, please, your introduction?
Hi, thanks for inviting me. My name is Vlastil. I'm leading the Cardi AI team. Cardi AI is an innovative solution for long-term remote ECG monitoring and detection of the heart arrhythmias. It's like prevention for stroke, heart failure, or early onset of dementia. We are currently expanding across the Europe. We go through all the pain of the MDR certification as Miki with his solution most probably as well. So I'm on the same boat. And last 15 years, I was working in Southeast Asia, scaling up the companies and building the startups there. So yeah, that's it. And thanks for inviting me.
Thanks a lot, Vlastimil. We have Richard with us, dialing in from Netherlands. With Richard, please, quick intro.
Thank you, Pankaj. I'm very humbled to be here. It's a proud honor to be here with such esteemed leaders in their field. My name is Richard. I'm a digital transformation and strategy leader for one of the largest global companies in dentistry. Prior to that, I became head of Europe, Middle East, and Africa for Zimmer Biomet when I was 30. One of my key core competences is scaling digital technologies across the globe. My academic background is from Nijrode, where I focused on strategy and finance. Later studied at MIT, digital transformation. Concluded at Harvard with Professor Porter and Kaplan, focusing on digital transformation, looking at patient outcome and cost. Recently, it's 5 years ago, became the chair of the AI and Cardiology Working Group, where we do groundbreaking work in finding new market capital and preventing disease detection, in this case, cardiology. And for that, I'm very humbled to travel across the globe for the Middle East region, and you get to learn and meet with inspiring new people like yourself. So I'm excited to be here.
Thanks a lot, Richard. Again, thanks a lot, all the panelists, for your time today. As I requested earlier, please do not hold back, do not hesitate, because Miki is fully ready with his answers and an ice bucket. I'm sure you are going to enjoy this session thoroughly. So please be as open with your questions, feedback, insights, guidance as possible. Now, I would request Miki to do a very quick introduction of himself and then dive into Vitalerter pitch. Miki, please, floor is yours.
Yeah, so thank you, everybody, for having you here. And I hope that it will be quite interesting. I'm ready, as Pankaj mentioned, for anything. I'm engineer in my background. I have executive MBA, serious entrepreneur. This is my fourth project. The previous 3 projects were acquired. Hopefully know the direction. Last one, company called Dune Medical Devices. We have developed real-time system that help breast surgeon to characterize clean margin, got the PMA approval, commercialized, and then acquired by American health company. So that's a background. Then, of course, I will dive in Vitalerter in order to share with you what we are doing, what we are addressing. So let me share my screen. So, yeah, I assume that you already see the screen, right?
It is coming up.
Not yet the presentation. Okay, one second.
Not the presentation yet.
Now, okay?
Now we see your desktop.
Still good?
Yeah, you want to open your presentation. Okay, now we see the presentation. Please go on the presentation mode, Miki.
Sure. Okay, so we are at Vitalerter try to address, I think, a global challenge which is related to aging and the type of customers that we are accessing to our nursing homes, aged care facilities, skilled nursing facilities, assisted living, and in the later future, of course, home care operators. And the key pain points that we are addressing are classified into 2 parts. One is the resident safety, and second one is the staff or facility efficiency. Now, some of the challenges that they are facing can be seen here. Chronic staffing shortages globally. United States, for example, 2024, 400K missing nurses. High incidence. There are average 3 to 5 falls per 1,000 beds per day. Pressure injuries, 5 to 15% again per day, and unnecessary hospitalization. And the current method is more manual workflow method, is reactive rather than proactive, costly, and create errors. And of course, using traditional tools, including wearables, cameras, nurse call system. And we address it starting, from the, I would say, bad management. If we are dealing with the residents, so we understand that they are passive mostly. So we have developed a unique contactless biosensor. You can see in my camera that this is a core that by attaching simply below the bed frame, as you can see here in the picture, the bed start monitoring without touching anything on the resident. Okay, like a continuous heart rate, respiration rate, heart rate variability, stroke volume, and some other vitals. This small box, of course, can be attached also below wheelchairs or sofas and require only Wi-Fi, which means that we don't require any special infrastructure, any special IT expertise. From that point, the device collects the residents' vitals, which I mentioned before, and send them to the cloud. In the cloud, we have built machine deep learning algorithms that build patients' personal 24/7 behavior and dashboards that allow staff members to personal alerts to each resident. So the benefits that long-term care facilities are enjoying are enhancing resident safety, improve work efficiency, its compliance by auto documentations and reduce errors, and improve quality of care for the residents and of course for the families. Our global footprint currently are serving more than 160 facilities and 30,000 beds. Our unique or core business is a smart bed. So far 30,000 in 16 countries. We got real world NHS validation, real world evaluations, and we got also the European medical device approval, and we are now in the process of getting the 510K class 1 in the States. We have currently 3 entities, Israel, China, Australia, and JVs in United States, Singapore, and Austria for the DACH countries. Some of the selected reference can be seen here from nursing homes, from geriatric hospitals, and also some new deployments in various locations. And the impact is already proven, again, by independent reports and the pilots done by end customers or even by care providers. So in the UK, we see 73% fewer falls and ambulatory calls and more than 2,675 fewer turns. I will explain how we do such thing. In France, also 80% fewer ICU admissions, and in China, 96% alert accuracy and 0 adverse events. So how we do so? Some of the features can be seen here. Through the device under bed, we manage actually the bed occupancy, including in-out bed, automated of the posture change and turns, measure continuously heart rate, respiration rate, and have a central monitoring system that allows virtual checks and of course a BI reporting system that allows the managers to improve safety and efficiency for their staff. We have built on top of that an automation solution that by adding to the staff members a smart tag, again, you can see how it looks like in camera. So this smart tag actually allows the automated closing loop. So let's take an example. Let's say the device under bed detects a turn requirements. It sends a turn during night shift, and the care on duty once come and do the turn, the device approves that the turn happened, and record whom did it and what was the quality of care in the management system. So there is no any manual process in order to close all this loop, and you can imagine it for any relevant emergency situations or any activities that need to be provided to the resident. Some of the proactive care safety applications are fall prevention, bed occupancy, bed exit, away from bed, sleep quality reports, wandering, and also automated posture change management. The digital management care activities allows to objectively evaluate that any activities that need to provide to the residents anytime during the service is approved, again, objectively and recorded in management system. So some of those can be seen here, like, you know, showering, diapers replacement, a turn, of course, any bad activities that are provided to the residents are managed through here. We also have developed an additional device, which is a biopatch for those that are on the move. So you can see how it looks like. This one is a reusable device that by attaching to the patient chest, he can be monitored 24/7 wherever he is. So the combination of these two devices, plus the advanced machine deep learning algorithms, allows continuous monitoring, management, and proactive care to the residents. In terms of the key differentiations that we have over competitors, so we are combining AI plus contactless sensing, which is rare in the LTC sector. We already got the regulatory approval and the UK NHS objective approvals. We are having growing proprietary data sets through the 160 locations in which we are running and collecting a huge amount of data in the UK, US, Germany, China. And of course, we have a proven time savings, event reduction, and scalability. Business model is a combination, or I would say a hybrid model, which we sell one time the hardware and installation, and then we have a yearly subscription fee, which allows to enjoy continuous revenue streaming. So taking average a 100-bed facility in which 80 residents are using Care Plus and 20 residents that have Care Premium, which is an advanced care services, brings to an average of 25,000 USD income. And with the premium services that we are adding along the time, we expect to grow by about 30% of this amount. In the US, we have been building our strategic collaboration with the syndicate. So we already have a 10,000 bed rollout with leading SNF operators. We opened a JV in the US to gain such thing, and having an integrated roadmap with the leading EHR system, Point Click Care, which covers about 65% of the US market, and a partnership with the VC called Clarim, which expands as the healthcare networks. So we are safe patients, empowering staff, and smarter operations. And of course, we are looking for partnering in order to adopt this solution to millions of users.
Fantastic. Thanks a lot, Miki, for the quick presentation. And I think you should be ready for questions now, right?
Sure.
Okay. Fantastic. Panelists, please feel free to unmute yourself and ask questions to Miki.
Yeah, maybe if I may start,
Okay.
I'm completely missing the competitors' analysis. Is there anybody else who is doing this type of solution? What are the competitors and what is the differentiator?
Yeah. So I would split this question to two parts. One part is those contactless technologies. Again, contactless, unlike the wearables. So contactless technologies, there are two of its kind. One is a radar, which is something that you put on the roof, and then it's mainly follow motions of the resident and can alert about falls, things like that, but of course have difficulties in terms of accuracy of measuring continuous vitals, and also high amount of error rate. And the other one is the underbed pad that you put, which is more old-fashioned. It's an electromechanical solution which degrades in terms of performance and need to be replaced quite frequently. We don't treat those as a competitors because we are, as you can see, providing a platform which address not just the patient safety, because those technologies currently concentrate on patient safety, but also on the efficiency. So we treat the second part of competitors like those health record system. As I mentioned, one of them, Point Clicker or Epic, which are mostly manual management system, because the staff members spend average 30% of their time typing manually what they have been doing, and it doesn't have the ability to have a proactive, real-time and preventive solution, which we provided.
I'm familiar with the bed pads quite a bit. And just to kind of give the other panelists a little bit of an idea of what he's talking about with the breakdown on those pads is also results in what's called like a warning overload. And so what ends up happening when these pads begin to age out, they begin to trigger their alarms. And so typically if you've had one for a while, the alarm's going to go off at the nurse's station continuously. Which is it's a bit of a challenge. Um, I do have a question that's on that, but also going back to this slide right here. If you look at the bed on the lower left-hand side here, um, it's up against the wall. There's a bed rail that's on one side against the wall, which is fine, but that bed rail that's behind the bed there. Um, that was, I take it that was removed to install the device, correct? And
Yeah.
you don't need to know the answer to this question or not, but it would be interesting to know whether or not they put the bed rail back, because if that was in the United States, like if that was in Canada, or in California or in Florida, that would be what's called an IJ, immediate jeopardy, if that bed rail would be put back on the bed. And so that's one area that if that bed rail is remaining off, that would be an interesting way to point to saying, there's also this other layer of benefit for the platform that you have that can be immediately adopted. Yeah, because that those types of, because you it's considered a physical restraint if there's bed rails on both sides and the patient's bed is not up against a wall. So just kind of like point that out. If I apologize for interrupting, Vlastimil. My question is on the 80/20 on the go-to-market slide. You only have 20 getting the premier version. Can you explain why?
No. It's I just took an example to show the yearly cost for average facility. So 80%, let's say 80 residents, it could be 70/30 or 60/40, depends on the facility.
Right.
But assuming that's the most common one, which 80% are using the basic service, which is the Care Plus. okay, which covers what I mentioned here, bed occupancy management, fall prevention, automated turn management. Those are the basic. We treat them as basic, and premium, they are, I would say, the services that on top of them include also the automated care management and the efficiency reporting, which of course I'll be more than happy to share with you in real how customers are using and enjoying these valuable things.
I'd be interested in discussing that further. And specifically on the 80-20 breakdown, what type of when you were coming up with that example, and I know it's just an example, but were you using like current Medicare census? Would those 20 patients, would those patients be short-term rehab patients in a U.S. health system versus 80% would be long-term, not short, not under Medicare but under Medicaid? So there's actually different types of billing that's going on, because is that the case that you're pointing to here?
Yeah, that's also sure a case that is relevant.
Okay, so that's a much more nuanced real world case. Okay.
Yeah, I think thanks, Timothy. I have a couple of the ones. I think going back to the competition part, Miki, do you have the evidence about the inaccuracies on the radar-based solutions? Do you have publications that you have done that how your system is doing better in terms of accuracy compared to the radar part? Just beyond what you say as your words, so it's their word against your word. How would I see some of the publications?
Yeah, so first there are independent, again, publication that shows the accuracy of the radar technologies, and also independent reports that are showing the accuracy of our system. I gave an example of the UK NHS. They have run a 6-month trial in 6 locations across the UK. We were not involved. We just provided the system and devices, and they release official report, which is published in their website, which show clearly the valuations, the value proposition that our solution brings, and on top, and more than that, they put us as part of the reimbursement system solutions that customers across the UK are applying and enjoy fund deploying.
So thanks. I think I have seen that publication as such. It seems to be a standalone one. I don't recollect it being to be a comparative one. But if there is a comparative one, we can take it offline. But in my opinion, I think it's good to watch out that particular space more intently. The second point is that a little bit on the technology side of this particular thing. One is the device placement. So what's the accuracy level and then the sensitivity about you saying that, is this a particular suggestion that you can put the device on this side of the bed, or how does the device placement influences the accuracy and the latency part of it also? So I would also it's a 2-part question, but you can first address the location and then the latency.
Yeah, so we are not, the device and technology is not quite limited in the location. Okay, so customer can put it in the bed frame around. Okay, and we one of the key things in our technology, which it is a dynamic solution, which means that it continuously in real time collects any changes that is happening around the resident, the bed, the environment, okay, and automatically adapt the parameters without any human involvement, of course. Yeah, if you understand, tens of thousands of used devices cannot be managed by human, and automatically adapt in order to make sure that everything is accurate. Okay, so that's a thing. As I mentioned, we got already the European medical device approval, which is an official independent best approval that can be taken in the Europe market. And I'm sure that by Q1 26 we'll get also the FDA approval for that. Now, in terms of the latency, we are a preventive solution. So preventive solution means that you need a zero time to make sure that the care on duty got that emergency alert.
Yeah.
Okay. So actually, all this loop is not an issue because again, you can see also through those independent reports, but through many other case studies that were run, that the alerts come couple minutes before resident, for example, attempt to get out of bed, at least couple minutes, which means that the staff on duty that gets this real-time alert have enough time to come and help resident, for example, in night shift, to go toilet and return back safely to his bed. And the bottom line is that we show, as I mentioned, reduction of more than 65% of cases in comparison between. That's what the Ministry of Health of the UK have run. They took 2 departments in one location, one department equipped with the Vitalerter, the other department without, and they just run it for 6 months and collect the results out of these 2 and compare it to the historical 6 months before.
Okay, I let other panelists to chime in. We'll come back again. Thanks.
Thank you, Kedar.
Well, so thanks for the perfect introduction, Miki. Good to see you again. Your 10,000 bed rollout, it sounds impressive, but per your view, what are your biggest bottlenecks in that sense? I mean, that you hit in deployment speed, aligning with the internal IT infrastructure, staff onboarding, ongoing support, when scaling to enterprise level. Because it's my view that you do have an impressive toe between the door, but to really scale it to the next level, how would you approach that?
Yes, so what we have improved based on the experience that we gain is the adoption phase. As you know, any technology that you try to adopt takes time. You have staff members, they are very busy, they are not tech-oriented. So all those things are relevant also, and even more in the market that we are talking about. So we have shortened the whole deployment cycle. Installation, let's say the same example, 100 bed takes less than 1 day to complete full installation, which means to equip the entire 100 residents with the smart monitoring. The connection to the cloud, which doesn't again require any on-premise infrastructure, etc., is like, you connect your smartphone when you come to a new location. Okay, so that's done. Second thing is staff adoption. So thanks to the automated adoption, again, just to remind you, device continuously monitor and the badge continuously close the loop. So what we do when we start the first week of this facility, we don't require and we don't train them for any specific software, but just ask them to carry the tag and let the system run. System is learning the routine cycles, okay, and start, classify and automated already part of those activities. So within few days or within a week, the facility, the ward manager or even facility manager can just go to the report section and start seeing very interesting data, okay, which is a strong driver for him to make sure that things are done well. Let me again share with you, and I think it will explain best. You see this dashboard?
I understand the dashboard and how this works from an operational point of view. I think the key question is, I think you do have an initial foot between the door, but if you're really looking to scale to enterprise clients, the threshold where they will judge you on will be significantly more robust. So what I'm trying to punch at, if you are opportunistic in converting the low-hanging fruit, and how will that scale to increase your total value? So let me pull through on that question. on prioritizing expansion across the US and the EU and the GCC regions where we're active at, and what framework you're using to evaluate. For example, if you have a structured cadence for implementation, how would you see that for a reimbursement fit? Some markets will have some slight differentiations. Any regulatory friction to the first speaker due to compliance or non-compliance, and payer incentives per that market, as elderly care is differently structured. And I'd like to see there if you have a real strategy behind that, or if there is space to further improve upon.
Yeah, the space is already there for sure. What we have done is that, as I mentioned, we build in the US market the syndicate that is a composed operator, mid-size East Coast operator that manage about 60,000 beds, and also we have for the clinical approval, we have another group that are supplying already such process, not just for the clinical approval, but also for the compliance services to the same customers, the same type of customers. So with these two partners and with our technology survey, we have this syndicate which accelerate the process of gaining more and more customers, and also make sure that the compliance is match their need. That operator have a heavy experience with the CMS reimbursement system, Medicare, Medicaid, okay, which is also a valuable things in order to find the right way how to get in and enjoy the reimbursement system.
I think that's more or less, and if you don't mind, because I think so I think I converted for Philips most of the US market on mobile C-arm, so I know a thing or two on converting large scale clients, 120 hospital settings. And what I know is that liability in the US market is a risk that you cannot bear. So I'm being a bit tough on these questions because I'd like you to succeed. But you also invoke artificial intelligence in a certain sense. Now that's my core specialty. In that sense, so you would look at sensitivity and specificity to predict certain falling on the elderly or frailty. One law case can bust your business in that sense and your reputation as well. So we need to be extra clear on your governance. How are you structuring your governance model? How are you modeling your monitoring? And how do you apply your change control strategy to secure that your predictive algorithm does what it say it does, and how robust are those studies? And I'll make that a little bit more condensed. In the UK market, if you compare walking with crutches versus without, of course you're able to walk better, and I think your system shows that. But what I'm looking for, it's the question behind my question, and there are low-cost competitors. I've done some pre-analysis after our call. I'm sorry I didn't get back, I was traveling. Your AI governance can be your biggest asset or your downfall. So to end the question, how are you structuring your governance, your model monitoring, and your change control strategy for EU and US?
Can you clarify what you mean change control strategy?
Sure. You aim to convert sizable hospitals. I mean, 10,000 beds, it's nice, but if you have 700 million people in your target group, it's a drop. And I think the potential is there. If you would like to over-deliver, you need to have a structured implementation of your technology. You need to have a double-blinded study protocol over several sites. You need to have specific parameters. For the AI technology, you would require for an FDA analysis a sensitivity and specificity. It will take 6 months and some work around that. For a medical device technology implementation, and just to make it practical, let's see, where's my notes? To sum up, and let me simplify, how do you protect against adverse risks in the business because elderly people tend to be well insured for all forms of legal or medical items. So to your view, how do you structure your governance for the EU and the US market? How will your model adhere to local policies, governments, and the larger clients? I mean, the tenants of this world who have 120 care systems, 500,000 patients in once. They'll like some proof.
So you mean
how would you accommodate?
Care, you mean the let's say the medical regulatory approval, and also
you have several
objective real world evaluations and case studies that done for by various customers are not.
The case studies are nice, but it's an existential risk for your company because I've been working with the Chinese market as well. You have a lot of low cost cameras that you can fit on the roof with an AI algorithm. And what you need to do, because I believe in your product, I think to really scale it, you need to look at the robustness of the solution itself and then adjacent to the medical technology on the artificial intelligence itself. Because if you make predictions and they don't follow through, although they do not have an EU AI Act in the US, but we do have one in Europe, you'll be in litigation until, well, it's something that you can defend easily by thinking, by proving that differentiation early in an accurate manner. And that usually goes in clinical outcome and then the cost outcome. And then you would have the two, and both will be on value-based healthcare. So that's, you can put that as a letter to file to the FDA or the governing body. That tends to work.
Official organization, like a global official or
no, it's a good counter question. I think what's helpful is your product needs to demonstrate that. So you'll have several governing bodies, local administration, medical device guideline, FDA approval for your product itself that you would need to provide documentation for. To the first question, first speaker. Any risk exposed to the elderly can be a flag, but that's just under the usage skill. And I think you're going way further because you predict fall analysis. What happens if you don't predict a fall? And for that,
if I
require,
Go ahead.
You would require a double-blind study. No, you're good. I'm just getting started. So but I think if you would really like to, if you really like to scale to the larger corporate clients, I think you would need 2 studies in the US, both on outcome and cost. In the EU AI Act, you have by mandate. It's not that I made it up. You would need proof that your AI works on 2 outcomes, and that will be the basis for a document to work with the local government and reimbursement as a fast track to commercial success. So differentiation here can build your positioning, and we're curious how to deliver that. And the second is on the pragmatic. A nurse, they're super busy. So a proper training and implementation program. So those were the clear.
Yeah, so I think building on what Richard said, I think what's really required beyond the case studies and then some of the quantification that you have achieved, certain specific things like the sensitivity, specificity of the deterioration that you're actually capturing and going to report. You'll have to capture the positive PPV and NPV, and saying that at 1 hour interval, 2 hour interval, 6 hour interval, 24-hour intervals, your prediction confidence that is actually happening. And that particular part has to be captured as part of the studies, publications, as part of the input to the government bodies and agencies, what Richard is referring to. And that, I think, that is very essential to build on as you build the evidence part of it and de-risk the business as what Richard is referring to.
I think that's a fantastic feedback and guidance, Miki. So we should take that positively and probably think about it as we move forward with the business, right?
Sure. That's great.
I think to your point, I think your positioning at the primary level is super good. And for value creation and your competitive next level, I think you absolutely have the potential there. But I think we need to articulate to really reach that global level.
Sure.
That's the reason that we call it roast session. So thanks a lot,
Yeah.
Richard, for starting the real roast.
Well, it was the question, right?
It's important.
Inputs, Richard. That's for sure great. Yeah. Okay. Offline. Sure.
I would like to see if Ayman has any questions. Ayman,
yeah. Yeah, thank you very much, and thank Miki. I mean, my colleagues, I mean, touching base the tech challenge and the regulatory. I will just put some note as outsider, the perception I got, and take it from a positive way, Miki, that you can work on, of course. In terms of branding, this is something maybe nobody talked about, which is, I see, for example, virtual nurse. So calling piezoelectric sensor under matrix a virtual nurse is amplifying the real the functionality there. So nurses make clinical judgment. Your sensor detects motion. So if patient die while your virtual nurse is on duty, who gets sued? So the facility or you. So actually, I guess maybe rebranding in a better way. That's really differentiate you and not broadening the let's say the functionality, which give you exposure for massive liability there. When you mention virtual nurse, that's one aspect here. And from the same aspect, which is branding and telling the value proposition, when you talking about contactless elderly care and avoiding intrusive tools and all of that, that's great. But to keep this consistent, I mean, I see it like bio patches, which is wearable devices. So contactless versus wearable, this is something need to be, let's say, maybe rephrasing in a way that we are saying that contactless is the future, and at the same time we are introducing patches that's that's touching the patients. So that's other part. And when we say that in terms of differentiation, the strategic differentiations, I see. I mean, from my point of view, I don't see that real strategic differentiators. When you talk about regulations in the MD and even the FDA, I see them like a threshold to enter the market, not a real differentiation, at least from my point of view. Because if you look at the competition landscape, which is missed in the presentation, even not similar company doing similar things, the conventional, typical way how they are doing things, the nurses, and looking also the next best alternatives to your solution, which is, for example, why they need to pay thousands for your sensors, while now consumers tools like Apple Watch and other, now they are doing such things.
Yeah, but not acceptable in the market that we are dealing with. Elderly people are not wearing watches.
Yeah, that's you are relying on the fact that maybe they are too old to wear Apple watches, right. or but I'm mentioning that as in I mean the perception. I mean, when you think about it, like investors or customers, also with a big customers with chain of hospitals, we think about that. For example, I know a chain of hospitals in the Middle East who are doing similar thing by using really one of the tool that in the market, commercial tool, but it's validated. And by the way, many of them now, the commercial one, they are seeking the FDA approval and all of that. So that's something you need to consider, that the fact that you cannot rely on that, okay, they are too old to wear Apple or Samsung or whatever. So that's one thing. maybe the last two things that I can mention, and I will leave the space for the team and for you also to think about it, is you mentioned point-click care integration. That's important. I see it very, very important, since also I'm coming from background of digital healthcare. If you are not in the EHR, the HIS, you don't exist in the healthcare settings. So that's something not highlighted very well. I see it there, and I think it's a major, let's say, concern that any hospital management that
Yeah.
will raise to about 160 sites. Yeah.
Can you repeat the last sentence, because the communication was broken?
Yeah, it's about sorry for that. It's about the integration. You mentioned the point-click care, which is in progress. I do believe that's an important thing to be highlighted very well, because I mean, for hospital management and from operational point of view, this is a critical point, that if you are not on the system, you are not existing. It's like a nice to have tool, maybe. That's it. So still now there is no clarity in the presentation about, do you have a signed ABA partnership or hoping nothing to break, is regarding the integration, and bear in mind that a lot of HIS EHR system on the market that you need to look at about how to integrate with. The last point, which is about spreading over the countries like China, Israel, UK, and now US. From my point of view, I see that you are widening. You are trying to do everything everywhere. I prefer really focusing on a real case, because that gives a concern, a perception that why you are collecting flags instead of dominating single market and focusing on a single case. Is that because, I mean, in this market, once you are in, the churn out is fast also? So that's a concern, and you need to elaborate or highlight it very well. That's from my side, and thank you, and wish you all the best, of course, in this fantastic solution.
Thank you very much. Just to point the last question, of course, very, very valuable comments, but related to the last one, the experience brought to us, the go-to-market experience brought to us to the point that the customers that we are dealing with does require to have a one-stop shop. Okay, let's separate between, let's say, the EMR and the rest systems. So those type of customers say, we would like to have, of course, one that include even the EMR. But however, we do understand that EMR is quite a long time deployments, etc. So at least the alternative one needs to address the key pain points that we have. As I mentioned in the introduction, resident safety, but also staff efficiency. And these two are a must. So that's the reason why I provided our automated care solution, which feed each other. In order to gain better safety, you need the help of or the involvement of the staff member. But in order to get the involvement of staff members, you need to show them value proposition for their workflow. So that's and the actual experience that we now are seeing shows the shortened cycle of adoption thanks to the automated solution.
Thanks a lot, Miki, for the insight. Yeah, Timothy, please go ahead.
Yeah, if I may jump onto that one-stop shop. In the U.S. market, you had a badge that was labeled on there. But have you had any success or plans to to present to like family offices or real estate investment trusts, because the device is actually part of, like, if you're attaching it to the bed frame, and if you're using things like a PCC or something like that, often those devices go under the actual physical portion of the building, and is considered as part of the lease in many type of operator agreements. So you may have a real estate investment trust, and they're going to own all the physical properties and even electronic properties for that facility, and it's leased out to the operator as part of their lease agreement. And that way, your technology stays with the building, and also like those family offices or real estate investment trusts, they usually have anywhere from 15 to 60 different operators underneath their belt that they just kind of like swap in and out as each one goes bankrupt, or whichever. Sorry for the doom and gloom type of view in the U.S. healthcare post-acute care arena, but there's a lot of turn with facilities in order to maintain, level of care for patients. You just want to just be able to pop in another operator that's already on your books, so it saves time that way.
Mm-hmm. Yeah, so you mean access though the infrastructure's owners rather than those that are temporarily managing.
Correct.
Yeah,
Correct. Because like Omega, they have 90 operators. Sabra has Sabra Welltower now. I think it's like close to when that merger gets approved, it'll be close to 100 operators in the skilled nursing arena. And to sort of like to leverage that is that. Yeah.
To support you, because I think Timothy and I agree. I think your true value to capitalize can be on the larger settings. And to Timothy's point, they structure it as a capex or an opex, or a capital expenditure of an operational one that impacts your finance model and your revenue stream. But to facilitate that, the points we just shared, I think, can bring you next level. Although it's a bit sharp for the roast comment, perhaps, but that can really, I would say 10x your output in the US market. And I agree with Ayman on the focus, but looks good.
Fantastic. I think that's a really interesting insight on how to go 10x from here. So thanks a lot for that.
And I'm concerned you don't have us looking at patient data here, right? Right. This is mock data, right? It's Mr. June down there. He's pretty active over there. So,
so I know, Miki, you have been answering all the questions. Now probably we can take a few minutes for you to ask questions and panelists to answer. So if you have any question, or if you want any insight or guidance on your go-to-market strategy or channel strategy, or probably regulatory framework, then please feel free to take those guidance from the panelists, from the expert panelists.
First, I must say that you gave more I would say tips and hints and recommendations rather than questions, which is great. Even though to part of them we do have the answers, but I prefer to listen and just to sync all those inputs. So let me ask a question, maybe from my side and from your broad experience. How do you see a need for such solution in the global market, or at least in those markets that you are experienced with? Do you see, with the improvements and the approvals, etc., do you see it like acceptable to be deployed with no limit, or you said, okay, it depends on the location?
Who wants to go first?
I can just give it a shot, and then others can pile onto it. I feel that it's definitely the location is important over there. I think we all agree, all the panelists and everyone would agree that the silver economy is definitely going to have a lot of pull for this particular type of solutions, whether it's US or even if it's like in India. I think it's going to be 20% population in India, for example, by 2050 will be close to 320 million. However, in absence of the reimbursement and other models, the business case viability in certain markets wouldn't actually make sense. So my answer to your query would be definitely because of aging population, there is a need for this. But where do you play as a location? And to Timothy's point and Richard's point, that with which partners you play, I think that will make a difference between success or fizzling out part of it. So the level of playing and then the location, I think, in my opinion, I think would be very, very relevant.
Okay, great. We went to the direction in terms of the go-to-market with the joint venture building. So we are building a joint venture in the key markets in order to enjoy the experience and the infrastructures that our partners in that particular market are having, and now not starting from scratch doing so. So that's the reason why we opened joint venture in China. We opened in Singapore lastly, in Europe, and now in the United States. So we experienced it already, I would say, in the Asian market, and now we duplicate it in the Western markets. So we are expecting to have this good direction. Second question: do you see I would say the regulators in the various countries shifting from qualitative reimbursement measurement to quantitative reimbursement measurement?
I'll quickly weave into this one. I think your time to market, the quicker you get on a more high level with lawmakers and top tier commercial entities or non-commercial entities based on outcome and cost, the better you're positioned you are, because technology goes extremely fast. In domotica, my apologies for the Dutch pronunciation, I know of several projects that may cut off your scalability. So to your point, what I would do if I were you and I would like to win, because we're here to win, I would build that GTM based on outcome and cost that would appear to your stakeholders, which be lawmakers, policymakers, larger companies, and that can build the value case ahead of time and then build onto that. I understand that you have a delineated market approach with Singapore, China, that also leaves you with a lack of span of control, because people tend to do their own thing. And you may want to think about having a global strategy that you locally diversify, but having the building blocks, my lawyer would say, like a knife, that you can pull it to the left or to the right, so that you can tip it to your advantage, because the time is pressing. And you do have some bets, but given the market opportunity, speed is the thing that makes airplanes fly.
Right. Okay, thank you.
Well, what do go back to addressing the first question, and which leads into the second question. So the first question for the need of such solutions. If I'm an operator of a skilled nursing facility, this is important to me, but it's not in the top 5. What I need it tied into is how it's going to improve my census and payer mix. Okay, so even since post-COVID in the United States, I'm still running as an operator. I'm still running about 3 to 5% below census levels in many of my markets. So I want to be able to see how this is going to improve that number. I also want to see how it's going to improve my quality scores. Now, going into the quantitative versus qualitative, this actually ties in because there's an area of payer in the United States, a market called an ISNP. It's an Institutional Special Needs Program, or DSNP. And these are this whole program is designed to reduce readmissions and to benefit and to reward post-acute care providers that keep patients from going back into the hospital, and it's done through managed Medicare. If I'm able to improve my scores that way, I'm going to be able to improve my bonus that I receive from iSNPs. Now, iSNPs are, in fact, DSNPs in general, and managed Medicare markets in the United States, or managed care market in the United States, are an endangered species. PACE programs are doing very well, but they're still very small. These iSNP programs, there's only a few 100,000 members nationally, but companies like GuideWell, which is a parent company for Blue Cross Blue Shield, the United Health Group, and so forth. The United Health Group, which oversees Optum, runs a lot of these iSNP programs as a TPA, and they're having challenges with them. So they're and so helping them with that, solving that problem, which your product does, because falls are one of the leading causes for patients going back into the hospital, could really kind of like help address that. So I see it. I see it fitting into that as that portion. You really need to tie it into census and improving that census and those quality care scores, right? Because that's how facilities are going to get reimbursed.
I'm asking a deeper question. Let me give you an example. In Australia, this month, a new act was released that the reimbursement is tied to the time that the staff members, like nurses, caregivers, are spending providing services to the care on duty, to the resident. Okay, so and in the act they clarify specifically, for example, for each residence, the caregiver need to spend about 44 minutes per shift, and the total staff members, including nurses, etc., 200 minutes per shift per resident. And based on that, they have the scoring and the payment for the reimbursement. Have you seen it in the States? No.
We do have it for a certain way in the Netherlands, because you're absolutely right. We get 8 minutes per patient. And I think that's where at Philips we built the value proposition DEX. And what we did to do for the C-arm suite, so we use, I was just making my notes. So the value there is patient value is the clinical outcome of the patient divided by the cost. That's the point that we make in value-based care. And what we do with the C-arm, for example, we take obese patients in the local market. You take a wider C-arm, so you don't have the hassle of finding several suppliers. That will save 8 minutes per day. That is one patient extra, so they can bill one extra, because in that sense, time is money. And if you can make these claims at scale, plus the regulatory compliance, you would have a stronger case building, and plus it would protect your, it would bridge your product proposal to the post-acute providers in that sense. So we're well aware. It's a good thing to work towards. Yes.
Okay. Okay. Thank you.
Thank you.
You're welcome.
Miki, I think you have asked some really pertinent questions for yourselves, which is pretty good. Again, I really want to thank all the panelists for your time today. It has been quite engaging conversation, and I'm sure that Miki got some really good ideas and questions to think about how the future direction of the company may look like, what kind of regulatory framework, go-to-market strategies, and pitfalls he may have to think about. So really appreciate your insights today. I think that's extremely valuable for Miki and Vitalerter. And I hope that we can continue these kind of conversations by having separate offline conversations, probably see how we can collaborate and support each other. So appreciate your time. Thanks a lot. And let's reconnect offline to take this forward. Bob, thanks a lot for your messages. I'm looking at them, and I'll connect with you offline. Thanks a lot. Thank you everybody for dialing in, and we'll reconnect.
Thank you very much, everybody. Thank you, Pankaj.
Thank you. Bye.
Thanks. Thank you. Thanks,
Bye.
Miki.
Thank you.
Thank you.